Good afternoon, everybody, and welcome to the present program session on VAP bundle. Is it still relevant for prevention of VAP in ICU? Myself, Dr. Sudipta, Medical Care Consultant, Tata Medical Center, and I will speak for the motion. I'd like to thank the organizer for giving me the opportunity to speak in this podium. So, what is bundle? Bundles is a group of interventions that, when instituted together, give better outcome than when they are done individually. And verb bundle is not an exception. It has some core components like elevation of the head end of the bed by 30 to 60 degree unless contraindicated, sedation vacation, that is turning off the sedation until patient is able to follow commands or is fully awake, daily assessment of readiness of vein, DVT prophylaxis, stress ulcer prophylaxis, selective oral decontamination, and selective digestive decontamination. And there are other important components are coming in recent studies, which, when included in the VAP bundle, can improve outcome. But we need to remember that as all fingers of one hand is not same, the evidence in favor of all the components of VAP bundle are not equally robust. Supine body position has been identified as a risk factor long ago for nosocomial pneumonia in mechanically ventilated patients. Studies, when they have compared supine position with semi-incumbent position, has found that clinically suspected pneumonia and microbiologically confirmed pneumonia are significantly higher in supine position, and it is as high as 3 to 5 times compared to semi-recumbent position. And it has been shown in multiple other studies also, just like this Cochrane review, which includes 10 trials with around 900 participants, and they've compared semi-recumbent position with a head end of 30 to 60 degree with supine position of 0 to 10 degree, and they have found the outcome of clinically suspected pneumonia is significantly higher in supine position patients. There are researchers who does not believe in this concept, who thinks that when you keep the patient's head end up, the chances of trickling of the pharyngeal secretion due to gravity into the trachea is higher, and the complications can be there because of this. So they have tried different positions like lateral tremulous position and compared it with semi-recumbent body position. The problem is that in our practice presently, we do not sedate paralyzed patients routinely in ICU, so what position may not be comfortable for the patient. And exactly that is happening with this study. Though the primary outcome of microbiologically confirmed VAP is significantly low in the study population compared to the control group, the study was stopped prematurely because of significant high number of adverse events in the study population. Among the all components of the VAP bundle, the daily interruption of sedation has the one of the highest or strongest evidence. It is also physiological because if we stop the sedation on a regular basis, the chances of patient will waken up is faster. As a result, the chances of extubation is also higher. So the duration of mechanical ventilation, length of ICU stay was significantly less in this subgroup of population. At the same time, if you attached it with the nursing protocol, it has shown to have a better outcome. So when nursing implemented sedation protocol is followed in the ICU, it shows the duration of mechanical ventilation is less. There is a significant decrease in the length of ICU stay, hospital stay. Also, the chance of tracheostomy is less in this subgroup. The most controversial intervention in this whole group is topical chlorhexidine usage for oral care. The previous studies and meta-analysis has shown that it significantly decreases ventilator-associated pneumonia, and the advantage was maximum among cardiac surgery patients. We can extrapolate the data of cardiac surgery into other surgeries and can comment that in surgical patients, in postoperative outcome has been improved or can be decreased, the VAP incidence can be decreased by chlorhexidine. But if you look at the recent data, it is not totally true. This may be because of change in the antimicrobial type in our oral cavity. We all know that chlorhexidine is a good molecule for gram-positive bacteria, but not as potent as like gram-negative for gram-negative bacteria. As a result, by killing the gram-positive routine commensals of our fadings, probably it can select out resistant gram-negative bacteria, leading to poor outcome. Another intervention, that is the giving stress ulcer prophylaxis, also has come under hammer. Multiple studies have shown that it doesn't have an extra advantage over placebo. Even in some studies has shown it to have harm. The chances of upper GI bleeding with placebo and with stress ulcer prophylaxis is comparable, specifically in patients who are already taking enteral feed. Now, if you look at the recent real-time data of ventilator bundle and the associated outcome, this is published few years ago in JAMA Internal Medicine. You can see that all the interventions of the ventilator associated pneumonia bundle has been used extensively over years and it has been increased, but all doesn't have received equal respect, like spontaneous breathing trial, which though have the strongest evidence, the practice is not that robust. But if you look at the other interventions and its relationship with the process, with ventilator associated events and other outcome, you will find spontaneous breathing trial and thromboprophylaxis probably will have some positive effect. On the other hand, stress ulcer prophylaxis and oral chlorhexidine doesn't have much positive effect. In fact, they have some harm. So if you again revise the VAP bundle, we'll find some interventions like head and down, sedation vacation, daily assessment of weaning and DVT prophylaxis have strong evidence to continue, but evidence for stress ulcer prophylaxis and chlorhexidine usage is not enough, and we should consider review. And in that situation, we need to extend the other options to include within the VAP bundle, like RD mobilization and exercise, subglottic secretion, drainage of the port, no regular circuit change, closed suction system, regular checking of ET cuff pressure, alcohol-based hand gel, and nursing training, and the list goes on. This has been included in different studies which try to compare VAP bundle with the standard care and show better outcome. So basically, as we are moving, we are gradually shifting from VAP bundle, that is ventilator associated pneumonia bundle, to ventilator associated event bundle. And with this evolution, the chances of better patient outcome will increase with the implementation of this bundle. So by this, I like to conclude my presentation, and I hope I will be able to convince my co-speaker so that he can feel free to join me in my opinion in this regard. Thank you.